also doing a little bit to prevent mental disorders in this baby right up to the point when the baby is a teenager. So that's kind of more bang for your buck right there. The second thing is that we have available already built and existing frameworks or platforms across countries and across different resource settings. When there's a pregnant or postpartum mother, there's always some kind of support that rallies around, whether it be prenatal care or whether it be support systems from the family or from the government, assisted nutrition programs, maternal child health services, immunization services. So it becomes all the more easy to integrate mental health treatments into these existing frameworks. The third thing is it kind of relates to the Lancet Commission's emphasis on the spectrum of mental well-being to severe mental illness. So when you're talking about emotional health in pregnancy, we know that even subsyndromal levels of emotional distress can impact the baby's well-being. So it becomes all the more important to ensure emotional well-being in the mothers and not just focus on pregnant and postpartum women with severe mental illness or with depression or anxiety. And, relating to the discussion on stigma, in some ways, stigma can be higher among pregnant and postpartum women because not only are they afraid that they're going to be judged for having a mental illness, but a lot of moms also are afraid that if they have a mental illness, then they're going to be judged as being not a good mother, not a good parent. But it can work in the other way as well, because working across different resource settings, I've seen that using the child's well-being as an entry point for drawing the mother's attention to her mental well-being often works very well. So you think about the lady health worker delivered psychosocial interventions and how they begin with the focus on the child's nutrition and the child's development, but then integrate maternal mental health treatments into that approach. So that's, I think, an additional strength.
Okay, thank you so much. I really appreciate your work, and also knowing that 1 in 7 women experience health problems in pregnancy, postpartum. It's crucially important. Can we hear from Dr. Jed Walls?
Sure. So it's a pleasure to be here. I come at this a little bit from a different lens, from the infectious disease lens. But really, my journey into this really started actually as a cultural anthropology major in college. And I went to Nepal for a study abroad program. And I ended up staying in Nepal for about 3 years. And I worked on a health project that was related to access to care amongst hill tribe groups in the Himalayas. And what I saw there really struck me really deeply, because I started to realize that there were populations on the planet who were really highly vulnerable. And so I got into infectious disease because I was really interested in vulnerability. And of course, when we talked about child mortality, a lot of that mortality continues to be, and certainly was, driven by infectious diseases. So I really thought of this as a way to address vulnerable populations. Of course, as I've moved through my career, things have developed and changed, but I still remain very interested in vulnerability. And now as we think about child mortality, which is an area that I'm really interested in, I think we can all look back at the last 3-4 decades and really be proud of the progress that's been made. There's been tremendous declines in child mortality around the globe. But we still have 4 to 6 million child deaths a year in the under 5 population. And that residual mortality is getting harder and harder to address, because the blanket interventions of immunization and water and sanitation and other things that we still have a lot of work to do, don't get me wrong, but those blanket interventions become less and less efficient as less and less of the population has the capacity to benefit from them. So we need to start thinking about smart targeting of the most vulnerable with those interventions that address the mechanisms that underlie their risk. And that smart targeting requires us to understand what makes people vulnerable. So as I said, I came into this very much from an infectious disease standpoint. And for one example, we have a large large project funded by the Bill and Melinda Gates Foundation called the CHAIN Project, or Childhood Acute Illness and Nutrition Network, where we're really trying to understand drivers of risk and drivers of vulnerability in young children. This is a project that we're conducting large studies in 9 sites in 6 countries in West Africa, East Africa, and South Asia. And we're trying to understand vulnerability and target those individuals. And one of the things that really jumped out as a marker of risk was maternal mental health. And in fact, we know that now in this cohort of high-risk children, that if a child has tuberculosis, certainly they need anti-tuberculosis drugs. But if they're not going to get those drugs because of maternal mental health issues, all the tuberculosis drugs in the world aren't going to help that child. And so for me, this was really coming around to understand what is the context in which maternal mental health really feeds into the vulnerability, and how does that impact how we address these with interventions moving forward.
Great, thank you. Also, I was on a study abroad program in Nepal as well, and I worked in a refugee health clinic. Side note, sorry. Also, you know what, I really appreciate what you talked about with specific targeting, because I think that's the opportunity to improve childhood survival. So really want to hear from the audience on some of those questions for you. And now Dr. Grace John Stewart. If you would.
I've got an abundance of microphones. I hope you can hear me. So I'm happy to be here too. And you can't hear me despite the time. Okay, let me just get one closer. Can you hear me now? Yeah. Okay, great. This way? Oh, thank you. Okay, I'll use the hand. Is that good? Okay. So I'm really happy to be here as well. And I come at this from a perspective of doing a lot of work in HIV. And my background is really thinking about women who have HIV and thinking about prevention in women, and then thinking about stopping children from getting HIV. And a lot of the early work that our group did looked at HIV mother-to-child transmission and delivering interventions in that sphere. And as part of that, a couple things became clear. One is that this piece that Amritha just talked about so eloquently is the interconnection between women and children is so clear. And there are opportunities to intervene that have efficiencies by the health system. The integration options that are there are really important. The other thing that's very clear is that as researchers, we often hear messages, help signals, when we ask about things like depression and violence and stigma, but we are so handicapped in terms of knowing how we should address those. So we have more straightforward approaches that we use in terms of getting drugs and antiretrovirals and tests, but we're not yet doing as good a job as I'd like to see in addressing some of the issues that women face and children face. The other piece of this is, in our work, we've worked with a lot of children and adolescents with HIV, and there are issues trying to understand how you tell a child they have HIV. When do you tell a child they have HIV? How do you tell a child they have HIV? And then how do they grow up carrying that diagnosis, and what can you do better to help them have that healthy approach to their HIV? Adolescents are the other group that really are so important to work with. And I just wanted to end on some of the new work that we're really interested in, and I think have so many opportunities for positive impact that have to do with multiplying the reach of the clinic through mHealth, through WhatsApp groups, and ways we can use modern technology to do a better job at supporting and extending the reach of our clinic with systematic systems.
Fantastic. Thank you so much. I really appreciate you talking about young people and mental health, particularly young mothers. I think that's a great segue to talking about HIV and on some of those other issues. So now we will hear, last but not least at all, we'd love to hear from you, Dr. Janelle Taylor.
Thank you. I'm really honored to be here, and I'm last, and at the end we talk about dementia. So that's what I'm here to talk about. And you know, the event started off with President Kause saying, among other points, that it's an exciting time in mental health because we can solve problems and there are effective cures and treatments. That's less true when it comes to dementia. So, but dementia is also, as we saw from the graph that Dr. Saxena showed, it's very, very prevalent in old age, and as the population ages around the world, the rates of dementia and the absolute numbers of people with dementia are skyrocketing. And though the prevalence, of course, tracks places in the world where people manage to live to old age to have the opportunity to develop dementia. So it's very uneven, and it clusters heavily in wealthier parts of the world. And medical cures and treatments at this point are not very effective, but that doesn't mean that there's nothing we can do. And I think that's a really important point and connects with the question that we had a little while ago about care. It's all about care at this point in terms of how we improve people's lives with dementia. About prevention, I think one of the interesting things about dementia is that it really forces us to exactly these big picture reframings that the Lancet Commission calls for, because the brain is so exquisitely sensitive and complex, and it turns out that the best way to prevent the many different kinds and sources of dementia is to have excellent health and care from in utero on. But just to turn to the idea of care, care is critical for the survival of people with dementia, because as the condition progresses, they'll need, predictably, a lot of assistance with many basic and more complex activities just to sustain life as well as well-being. And this is one of those areas where, as Dr. Collins said, you can, I think it was you that said that we can, Seattle is part of global health, right? You can study global health right here in Seattle. People in Seattle who are living with dementia are receiving care, often from people from all over the world, right? Care is part of a global system that's very, characterized by a whole lot of racialized, gendered, very unevenly distributed labor with complicated flows and complicated consequences, both on the countries from which many of the nearly 40%, according to the statistics that I was looking at, the 40% of elder care workers in this country are immigrants, and they are coming from many other countries with complex and sometimes contradictory effects. There may be remittances flowing home, there may be drains on healthcare systems, there may also be care gaps left at home. Who is taking care of their own elders at home? That's another question. So I guess the idea, we were asked to think about how to solve challenges, and I guess one thing I would throw out is that one way we can start is just by asking with seriousness the question, who cares? Right? Who actually does the work of caregiving? And how does that connect with things like, for example, whether we do or don't have a coherent healthcare system? And also, more broadly, who cares? Like, how can we mobilize the different constituencies that care about old people and other people who need care to understand and address dementia and other chronic and, at this moment, incurable issues as problems of global health. So I'll just end with that. Thanks.
Thank you. Well, let me just say thank you to all of you. It's really fascinating to hear the whole life course, and I'm glad you brought up about the care workers, because I don't know if you know the campaign Caring Across Generations and One Fair Wage campaign. They're all connected. Everything is connected, people. So with that, any questions for our illustrious panel? I have my own question, starting with you, Dr. Janelle Taylor. How can biomedical research on dementia be leveraged to address the questions of care and social support?
So I think there are ways that we can take some of the very biomedical thrust of a lot of research that's happening now, and try to reread from some of that evidence what we can find out about family and social support and care resources. More generally, I think there just needs to be a shift in terms of allocating more funding and support and energy and ambition toward researching these broader contexts that have such intense consequences for people. So we need more people actually looking at these questions and taking them seriously.
Go ahead.
Okay, thank you. This is sort of a researcher type question, but along the lines of the domains that you guys are working in. So we did an investment case, an economic analysis of adolescent risks for non-communicable diseases. And we were only able to get really good data about some of the sort of obvious risks: tobacco, alcohol, obesity. And I really, really wanted to include mental health, but I couldn't find good information. So I'm not really asking you where's that information, because we talked to a lot of experts and I don't think it's out there. I'm not sure. But what I am asking you is, in what kinds of domains should we be looking? If we're going to be looking in, say, other bodies of literature, or at least thinking about the types of impacts on adolescents of their mental health through their lives. I mean, obviously, a lot of other chronic diseases happen late in life. You know, so we know when that happens, we know what the impacts are in health and economic stuff. But the mental health ones are, you know, touch on so many other domains like family formation and employment and so on. So just wonder if you guys would reflect a little bit on what we should be looking at there.
I see some people in the audience that could actually address that. And, you know, I having talked with you just about this topic, I think in terms of the burden and seeing the peaks that start in adolescence and understanding why that occurs, I think there's room there to explore more. But I think in terms of the data or the places to look for data that you're thinking about, I would really wonder if there's some people in the room that could answer that better than I.
Oh, well.
Just briefly, I think one non-traditional source would be social media. There's a lot of information available about adolescent mental health kind of disclosures on social media, on Facebook and Instagram, and how can we use those platforms to not just identify these adolescents, but also provide some kind of support. So that's a start.
Okay, I'm going to jump in. Sorry, I'm going to jump in. There is actually, and this is not going to surprise anybody, pretty good evidence that if you're an adolescent and you're struggling with a serious addiction problem or a mental health problem, it has some effects downstream for you, right? If you're one of our 50,000 students here and you're seriously depressed, or you know, you're depressed and you spend most of your day in your dorm room smoking cannabis, you know, that's probably going to have an effect on your path through this organization, right? And what comes after that. So there's also very good evidence that we have good interventions for substance use in adolescents, for depression in adolescents. So I think all the dots haven't gotten connected yet, and nobody's done a great economic analysis, but you know, I think you could make a pretty strong case that if we connected the dots here in the right way, that it's a fabulous investment.
Maybe to add to that, in JBD, we've looked hard at potential risk factors that we could quantify for mental disorders. I think one of the considerations, it's not like cardiovascular disease where we explain 90% of disease with established risk factors. Also, the fact that these disorders are very common across the world means that it's not linked to traditional things like education and level of development. There are many other factors that must be playing a role. But there are established risk factors, and we'll soon publish the first set of results where we've quantified the effect of bullying on depression and anxiety. And I think in the areas of violence, there are more areas that we potentially in the future could quantify beyond bullying and child sexual abuse and intimate partner violence, which we've been doing for several years.
And when's that study coming out? When did you say it was going to be released?
Next month, the next round of GBD will be released in Lancet. and soon to be followed by a specific paper on the bullying analyses.
Yeah, just put that in your calendars, people.
Does that answer your question, Rachel? Or
yeah, that's very helpful. Okay. I think that you're going to have the same hunch that you have, but it's connecting the dots and finding data. Because there's lots of good information out there.
Treatment trials for depression, you'll have the best effects in adolescents. Much better than older adults. Part of that is time. And they're a lot more resilient than somebody. But if you look at just the treatment literature, tremendous effect sizes. That's good. That's good.
And there's that great slide.
Sorry, as an outsider, not in this world, but who's now finding myself more and more involved in this. I think one of the issues that I found in my literature searches for data in this topic was that most of the mental health literature that we were able to find in relation to child survival was really dealing with mental health as an outcome. So most people are collecting data with mental health as an outcome, and not a lot of people are including mental health as an exposure and a risk. And so I think there are opportunities, maybe not for existing data, but in the future to try to capture more mental health issues as risk factors for other disorders. One area that really struck us in the work we're doing is that we did do PHQ-9 screening of mothers, many of whom are adolescents across the world. And the symptoms that really seem to be highly associated with risk in children are not the severe depressive or psychotic symptoms. They're really the anhedonic symptoms, and really makes sense if you think about what that might mean for a mother trying to care for a young child or multiple young children. And I think those types of symptoms could also be screened for many reasons other than as part of a thorough, complete mental health screening tool. And they could be incorporated within, for example, maternal child health clinics, prenatal clinics, in ways where even if and we could argue that a full mental health screening should be done, but even if it isn't being done, I think there's relevance to those questions being added otherwise.
And I'll just refer you back to the slide in the Lancet Commission that had it showed the life course and the age at which there was elasticity in the brain, and it was all under that it just going back to that idea that 50% of mental health conditions show up at 15 and then further 75% by age 24. Just to put a plug in for young people in mental health, since that's what I work on. I wonder if there are any other questions. Oh, please.
So I'm a little smaller than the average person. I have a question. In many cultures, pregnant women are a very vulnerable population, especially with gender-based violence and in places of conflict. And admitting mental health problems could make them even more vulnerable. So I'd welcome any thoughts on how to go about a situation like that. Or I know a really easy question.
No, that's a great question. And you're right, like I mentioned earlier, mental health problems by themselves carry a whole lot of stigma, especially more so in some cultures than others. And when you're talking about a pregnant or parenting woman, there's the additional burden of, will I then be considered an inadequate parent? In some countries, like here in the US, that's more systematized in that, Child Protective Services gets involved and may remove the child from the home if the mother has a severe mental illness. In other settings, when it's not systematized, there's still the approbation from society or taking over of the caregiving by a grandmother or an aunt. So that is definitely a problem and does lead to women not revealing the symptoms that they're going through. One of the solutions is to try and focus on the child's well-being. And kind of integrate maternal mental health supports into platforms which already exist which support the child. So then although the primary focus is on the child, you're trying to sneak in some maternal mental health support in there.
Any other questions? I have a question.
I had a comment too.
Go ahead.
And it doesn't answer your question, but it just acknowledges that, it's obvious, but there's such a cycle between this partner violence and mental health symptoms, and the cycle is, just a vicious cycle. And so where you find it or where it's revealed to you might come up with reports of violence or might come up with mental health symptoms. And I think understanding how you intervene at the different points that it's revealed to you is important, because what can you do at the point when you're having violence reported to you? What could you do that could help in terms of a safety net? That might be something that's very powerful preventively. Alternatively, somebody might be at risk, as you commented, of violence following episodes or stigmatizing episodes. And so if that's the case, what can you do as a safety net? So I think pragmatically thinking about where this falls in this cycle is really important, because they're so intricately linked in many of the settings that we work. And sometimes seeing one or the other should be a signal that, we look out for both.
Anybody else want to comment on that? Or okay, then I have a question. So most of you, I think, have worked both overseas and in the U.S., and I'm curious about what similarities and differences you see in mental health treatment access, barriers between countries, and if there's a common denominator or not, or any sort of comments you can make about that.
I can speak to the population I prominently worked with. You're right, the barriers to access are very different across countries. Sometimes there's no access to psychiatric treatment. There's also wide variation in what people attribute their mental health symptoms to. And so as a consequence of that, what their first go-to is for treatment, whether it's a religious treatment or trying to get social support or trying to get psychotherapy or medication. I think with the pregnant and postpartum women, what the similarity I've seen or what's universal is kind of the importance that's given to that critical period, the postpartum period, or the caregiving relationship between the mother and the baby, and how people will do anything to help, support that.
Yeah, I've seen that too.
I guess one comment that Simon brought up yesterday that I was really interested in is that in some cultures there aren't language, there aren't words for some of the symptoms that, and the language doesn't exist, which makes it difficult for people to start to access or understand how to care. And so the prevalence of language, even if you live in the United States, a lot of the terms that we use for syndromes and other things are common language. But if a language like Swahili doesn't have a word for depression, what do you do with that? How do you make that a clinical interchange? And I think that was a point that really was striking to me when you brought that up yesterday.
Yeah, I would just add, in my experience now working in, 14 countries, one thing that really strikes me across all of them is how, particularly for young mothers, you have in many situations, including in the United States, women are often isolated for a variety of reasons in the home. And then you add on to that pregnancy and the peripartum period where it's even more isolating. And then you add on to that any stigma associated with mental illness, which is even more isolating. And so it's a self-reinforcing pattern of isolation, which then precludes any social support. So independent of any intervention, medical intervention that's needed, I think there's a lot we can do to build social support networks. And some of those can be real, getting people together. But as Grace alluded to, there are ways to use technology or other interfaces to create networks for people that do seem to be really empowering. They do allow people to exercise agency, even in areas where agency may be pretty limited. And so, for example, we're doing quite a lot of work in Pakistan, and we're finding that actually providing a forum for mothers, young mothers, to actually be able to just communicate with each other provides a huge level of support that I think we all assumed was there already in the community, but isn't always so. So I would just add that.
Thank you.
My name is Ian Bennett. I'm a professor in family medicine. I'm a family physician and also in psychiatry and an adjunct in global health. And I am coming up because there isn't anyone else in line. So I just wanted, because I have had a conversation with many of these folks about things, but I wanted to chime in on your question because, and to add on to what Amritha and Grace John have mentioned, that one of the things that's really interesting to me about the language around mental health that, you see examples of it in all of the different countries where I've worked. As an anecdote, you can, all of us, I think, will experience, and you can test it out on yourself or your friends, start talking about perinatal depression. And what people will say back is, oh, you mean postpartum depression? Or they'll start talking about postpartum depression. It turns out, it's equally prevalent in pregnancy and postpartum. But we have a history based on the belief of more than 100 years ago and before that you couldn't get depressed in pregnancy because pregnancy was protective against depression, and the glow of pregnancy was a clinical term to mean that you couldn't get depressed in pregnancy.
Yeah.
So some guy came up with that, I'm sure.
Yeah, they certainly did, because they did not ask you.
Right. And also in Vietnam, in a project we're doing right now, talking to healthcare providers about depression and pregnancy, in our focus groups with them. First thing they would say is, what do you think about depression in your patients in pregnancy and postpartum? And they say, oh no, they don't have it. We've never diagnosed that. It doesn't occur. And then we describe the symptoms, and their eyes open and they say, well, yeah, that's very common. There's this interesting thing about language that creates barriers. And I would say that is a very interesting commonality across the countries that I've worked.
Yeah, thank you. I totally agree with that. Yeah, go ahead.
Just to add on to that again is this expectation that women are happy because they're pregnant or happy because they've just had a baby, again, can be very stigmatizing and an additional burden on moms to disclose their symptoms. Mm-hmm. That's across cultures as well.
Yeah, that's a good common one. Are there any other questions? Otherwise, I would like to ask Dr. Judd Walson if, as you are kind of like, well, I would like to ask all of you, but those of you who focus on infectious disease, how do you see mental health fitting into your research agendas?
Yeah, I would reiterate again that for me, I'm not one of those people who knew I was interested in, protein B7 or whatever since I was 2, or I had to focus on a particular virus or whatever. I've really come at this much more interested in vulnerability. And so for me, I think of infectious diseases as the consequence of being vulnerable to them. And it's very apparent to me the more that I do this, that the magic bullet that Bill Gates and others are looking for of a new laser beam or a new pill or a new app is only going to go as far as the support systems around families can leverage it. And I think that's true for all of the medicalized interventions that we have. And I think we're really butting up against the limit of our ability to really push this agenda forward. And until we address some of the social determinants of disease, including mental health, and some of the issues that are constraining families from having the most capacity to benefit from intervention, independent of the intervention specific for mental health, I think we're not going to get as far as we could.
That is a great way to end this session. Well done. We're a little early, but I'm going to turn it back over to Pamela. Thank you. Thanks, guys.
Thank you, Ada, and thank you, panelists. And thank you, everyone in the audience who's been with us this afternoon. This is really an invitation for you to see the breadth of issues that we think about when we think about mental health. And that global mental health, number one, includes Seattle, it includes our region, and it includes the wider world. And I think what's important in this last panel also is hearing about these similarities. And I want to come back to this theme that we've been saying, that when it comes to mental health, all countries are developing countries. We all have something to learn. But I think the other common theme is this, the Lancet Commission on Global Mental Health and Sustainable Development keeps coming back to this theme of our humanity and our mental health. And I think that's may sound trite in some, but that's central, because people are people. We often get caught up on, are the cultural differences going to be barriers to addressing these issues? But I think we need to realize that our motivation has to be to move beyond those cultural differences, and to recognize that people experience this continuum of mental well-being to mental disorder everywhere, and there are ways of tackling it. There are ways of tackling the disorder. We've heard about that. We've heard about treatment interventions. And when language and other barriers become difficulties in helping people to articulate what's wrong, those are challenges for us to embrace and to put our heads together to figure out. And that's what we welcome in this global exchange or in this community of people addressing these issues. So let's close for the day. Keep following us. There's the website for the Lancet Commission on Global Mental Health. Download the report, read it, and stay in touch. Thank you.